It's important to know that we don't want to set these guys up to be your legal advisors, so they're not going to go into detail and give you detailed descriptions of what they think the ACO rule is. This is more of a high-level general discussion. You know, what is it? How is it part of payment reform? So our panelists represent very diverse perspectives. I would invite you to look at their bios in the book so we don't spend time going over their lengthy and impressive resumes. I think you'd rather hear them talk and get into some good debate about how all this works. So I will briefly introduce to you, on my right, we have Will Groneman, who is the Executive Vice President for System Development at TriHealth. He is also, I note, the Chair of the Greater Cincinnati Health Council. On his right is Amy Frankowski. We practiced for only 20 minutes, so sorry. Frankowski, who is the Medical Director of Care Transformation for Mercy Medical Associates. So eager to hear about what her job is. On her right is Craig Osterhues, who is a healthcare executive working on community initiatives for GE Aviation. He is also on the board of the Employer Health Care Alliance and HealthBridge. And finally, on his right, we have Keith Mandel, who is physician and VP of Medical Affairs of the Physician Hospital Organization at Cincinnati Children's. Keith was also very involved in their workup to get the Pursuing Perfection grant. He's worked on the Aligning Forces program and was instrumental in our work as a community to bring Beacon to the Greater Cincinnati community. So, panelists, what I'd like to do in this first set of questions is have a question and have each of you respond to it in order, and we'll just start with you, Will, and try to limit your responses to 3 to 5 minutes so we can have everybody have time to get their responses in and then get some good dialogue and maybe even some good questions from the audience. So, here's the first of those general questions to each panelist. What is the difference and the similarity between the terms payment reform and accountable care? What is an ACO in your view? Will.
So Bob, you want me to just answer that first question or the second one as well?
Well, just the two of them, but you still have 3 minutes. Sorry.
All right. It won't take that long. So a lot of friendly faces out there. It's nice to see everybody. I don't get any smarter when I get up here than I am out there, so don't expect real pearls of wisdom. As far as what's an ACO and do we support it and what's payment reform, the way we look at it at TriHealth is the Accountable Care Organization is a specific payment program that's part of the federal health care legislation. And so it's not a generic term. It refers to what's in the law and what the recent draft regulations have come out that are under review now or in comment area now. And we, as an organization, don't think that we're going to participate. In fact, we're not going to participate in the ACO for a number of reasons. One is, probably the biggest one, is the attribution of the patients doesn't happen until after the evaluation period, and we're not sure how you manage a population when you don't know who they are. But also, as concerning is that we think that the reward, the financial reward, isn't high enough to justify the payment up front and the risk that you take as an organization. And so, you know, we're not going to pursue that. Now, having said that, as far as healthcare payment reform, there's a lot of other models that are out there that we are pursuing. So the value-based purchasing that has been promulgated by CMS, we are participating and gearing up for that. And that, you know, under that system, healthcare organizations will be rewarded initially for high quality and high patient satisfaction, and then eventually penalized for not having high enough quality and high enough patient satisfaction. And so we're looking at those and participating in those and gearing up for that. We think that there are other opportunities either in that will be coming forth around bundle payment and that type of thing. And so we are trying to get ourselves organized to participate in a changing payment structure but just not for the specific ACO offering that's part of the legislation.
Good afternoon, everyone. I'm glad to see that there are still some people in here with how beautiful and sunny it is outside. The first real sunny day we've seen, I think, this week. I am part of Mercy Medical Associates, and I wanted to address those two issues of payment reform and ACOs. I think that there are similarities in that both the terms are trying to address what we as a country are trying to move from more acute care episodes that are more fragmented in how we deal with them to more population-based episodes that are more planned out, thought about how we're going to deal with that care. And I think payment reform is a broader term, and some of the concepts that Will mentioned, such as bundling and value-based purchasing, are all moves to help us go from these episodic care situations to more care that has a quality focus. So some of those payments that we are also looking at making changes to address the quality that our organization is having so that we can participate in some of those funds. And I think that the ACO is maybe a subset of payment reform, but maybe goes a step farther in that I was going to give an example of a patient of mine. We'll call her Betty White so we can keep her anonymity and her HIPAA from being violated. And she might, under the current system of us trying to improve quality, I might address her diabetes care. I'm an internist and work in an office setting and might meet some of the measures for quality care, so I might get a pay-per-performance payment on top of my fee-for-service payment. Then she might go see her orthopedist, get her knee replaced. He might meet all the standards of care and his pay-for-performance measures and get pay for that. And then the hospital might also do an excellent job, meet patient satisfaction, get the patient discharged in a timely manner, and then not have them readmitted, so they get to keep all their reimbursement. And we think we have done a good job under payment reform. We all maybe got a little extra money because we've followed quality guidelines. But it could still happen that something could slip through the cracks. And when Betty goes to the ECF before she comes back to see me in the office, maybe her meds weren't handed off correctly, and she's on too much blood pressure medicine. She gets confused, she falls down, breaks her hip, and actually ends up being readmitted for a new problem, which could end up being a cost to all of us. So under the ACO model, all the providers have to think about her care. It's not just each individual's experience with her. It's not just when she's in the hospital or when she's under the care of the orthopedist or when she's at my office that day. We're going to have to look at the whole care continuum and say, what can we do so that each handoff is addressed, and we're looking at Betty as a whole person, as that patient, and not just a diabetic or a knee replacement or a hospital admission. So I think that's where we're starting to look at ACOs as where everyone has to participate in the care. And then if we're going to look at participating in such a program, we'll all have to take the risk if we all want to get the benefit.
Okay, I have to follow Amy. All right, so I'm Craig Osterhues with GE, so I'm a payer, so I look at this a little differently, and maybe not all these questions apply to my thinking. But so what is an ACO? To me, it's the organization of the health system to deliver accountable care. So something that Amy just described is something that we as purchasers of healthcare and as patients of the healthcare system would hope that we can deliver as a healthcare system. So that is the second part, perhaps, Bob, of your question. The differences and similarities between terms payment reform and accountable care. So now we're into what is accountable care, and in order to do that, the way we look at it is we're trying to transform the clinical setting, right? So whether it's a primary care office or the more acute settings, but we're trying to do clinical transformation. We have to have data and performance measurement around those clinics. We can't have clinics just saying, hey, we're a patient-centered medical home. We did this with BTE. People bridges to excellence. People got certified by NCQA. They got a nice certificate from NCQA that they were diabetic experts in delivering diabetic care. See in 3 years, pay you extra for that. 3 years later, you go to reapply for recognition, and 50% of the folks fail. It's just like a golf lesson. You're good right out of the gate, and then you go back to your old habits. So we have to continually measure the performance of the healthcare system. And the payers, that gets to the second part, the payment reform, it's on us to reward value. So reward high-quality outcomes and efficient delivery of healthcare. And that's the second part of the equation, but that will help reinforce clinical transformation.
Okay, good afternoon, everybody. Okay, being the last one to speak to this issue, I was wondering how much of this would be unique versus what we've heard so far, and I think actually there's a bulk of it that will be. So what is accountable care? From my perspective and in my experience, what that really means is define your denominator. Who are you talking about being accountable for, and for what? So what are the quality and cost metrics that you're being accountable for, and for what denominator, what population? So for example, it could be a population within a single primary care practice, could be a population across all the primary care practices, let's say at Mercy or TriHealth, or it could be beyond the primary care denominator. It could be lives within a region. So it first starts with what are we being accountable for and for what population? And then it's about building an infrastructure to actually execute, to improve those metrics at that total population level. I think as part of that, it involves a significant investment in primary care infrastructure as part of that equation, which I think understandably shifts resources. I think hospitals and specialists, there may be a shift of resources going from hospital and specialists to primary care because you need to have that primary care base no matter what level of denominator or population you're talking about. And I think the cost measure, if I just jump to that to make a point of emphasis, I think people are really talking about per capita cost. They're talking about the cost for that total population that you're focusing on, moving that in the right direction. So now what's the link to payment reform? My personal view about payment reform is that those payment reform models that align in terms of their design characteristics directly with what you go out there to achieve under accountable care, those quality and cost outcomes in the population, the design characteristics of the payment reform model should directly align with what those objectives were, because if they don't, then it becomes very distracting to what that primary objective was. So for example, Will had mentioned the attribution issue. Well, the payment reform design model doesn't adequately address the attribution issue, which then gets in the way of executing the improvement work. So we're not really talking about improvement anymore. We're arguing over the positives and negatives of what people at CMS might have designed as a payment reform model to arguably accelerate improvement. But what really happens is people say there's no way for me to succeed under that payment reform model, and we're no longer talking about what we were accountable for whom and for what. And I think that's a very big danger of the payment reform trend of what's going on. So let's see what else. And the other thing I just wanted to say is payment reform is not enough. If it doesn't start with the premise of quality improvement, particularly for a defined population, it's unlikely that payment reform will have the intended effect of moving regional, state-level, national dials, which is what insurers are looking for. It's what CMS is looking for. What could arguably happen, unfortunately, is the pre-existing high performers who would have lived under any payment reform model benefit from it. But those who are really depending on the payment reform model to trigger and accelerate their improvement journey, due to the design of it, may not actually yield that effect. And that's a real concern. So anyway, that's my perspective on it. Thank you.
Okay. Thanks to all of you. On this question, let's just make it a general question and jump in and have a comment if you would like to, as long as at least one of you responds with a satisfactory answer. We're at a meaningful use conference, right? So let's relate the two. How does meaningful use, as you understand it, support and enable the move toward payment reform? What's the intersection of meaningful use and payment reform? Craig.
Start with the simple mind, and then you docs can jump in. So the way I look at it is meaningful use is getting wired, using technology in a meaningful way. So I think the way Farzad described it during his talk was adequate. I think we get the idea. So, and there's financial incentives behind that. Now, I haven't done a crosswalk, but I think if you become a meaningful user and are recognized as a mover, as they're doing now, then you're well on your way to patient-centered medical home. And so meaningful use is getting technology, using it in a meaningful way. The way I think about patient-centered medical home is now you do more process improvements, perhaps open access on your appointments and extended hours and things like that, in care planning and team planning and those type of things. So really good stuff. So it's a step up beyond meaningful use. And that gets us toward clinical transformation. You still have to change the culture. Anybody that works in a large organization knows it's not just how you pay your folks and the type of tools you give them. They have to work as a team. You know, and everybody's been probably in tougher teams and they don't communicate well and the work just doesn't get done. Doesn't mean it matter if it's healthcare or making aircraft engines. So we need to get to that point. And that gets back to payment reform and payment innovations, the way we like to think about it. We have to reward those steps, but ultimately rewarding outcomes, improvements in quality, improvements in efficiency. So that's the way we look at it.
I'd add just a little bit to that. I think the meaningful use, and particularly the dollars behind the meaningful use, have been and will continue to be significant in getting EHRs into our physicians' offices. And quite frankly, I don't know how you do population management without an electronic medical record feeding some kind of a data repository that lets you look at the data for your whole population that you're responsible for. So sort of picking up on what Keith said, if you know that there's a group of people that you're responsible for providing health care for that is affordable, high quality, and has high patient satisfaction, with an electronic health record, you can extract a lot of information about that population, and you can design interventions and changes that will improve your numbers, that will improve the satisfaction, improve the clinical quality, reduce the cost going forward. So I think it's a fundamental part of the strategy of driving clinical reform in the United States that we need to have. The second piece is, and I'll just echo a little bit of what Keith alluded to, is I don't think the question is how does meaningful use drive payment reform. I think it's how does it drive the transformation of how we deliver care. And payment reform needs to come after that. It needs to support those practices that want to improve how we deliver care. It doesn't drive how we deliver care, because I don't think we've had any success in this country using payment reform is the primary motivator of change. We've done, the managed care plans and Medicare have done that for years and years. You've got to get the providers engaged in wanting to change, and then you've got to reward them for doing the right thing, for reducing costs, for improving quality, for improving satisfaction. And I think that starts with a fundamental building block of having the EHR and the doctors in a network of doctors' practices that allows us to accomplish those kind of transformational changes. So I think it starts with EHRs, to transformation of the delivery system, to transformation of the payment system to support what you want to get out of it.
Well, I think they've both said quite a lot there about meaningful use and payment reform. I'm not sure if I can add a whole lot more, but I think the one thing I would say from my perspective for meaningful use is that it's hard. I don't know how many practitioners or administrators who work directly with practitioners have experienced, but I think our group has found that it is hard to implement electronic medical record. I see a few nods out there, it is. And some of the meaningful use criteria might seem rather abstract to what we're doing. So just having providers engaged in meaningful use, I think, is not necessarily a motivator in and of itself, but if we can work through those steps, we start to see some of the benefits. And this is one of the first time that physicians and providers are able to actually look at data to, because everyone says, I'm doing a good job. But when you actually get to look at a whole population and see what you can do with that information, that maybe I'm not doing as good a job as my partner across the hall, and why are they doing better? That starts some of the processes. Well, why are they doing a better job? Or why is this other office in our group having so much more success with their outcomes? I think that's a real high benefit. And then we can start putting some processes in place to make changes so that we can deliver better care.
Okay, so the notion of you need better data, you need the technology is embodied in the meaningful use. I think we all agree that there's a component of the really being able to measure quality and improve it in an iterative way. I think the panel's made a great point about this is really about transforming healthcare. So, but at the national level, great deal of uncertainty. I think at the local level, there's probably a great deal of uncertainty. So what kind of strategies or approaches are you using to make sense of the big push and the big interest, and even potentially the opportunity for our community to approach, oh, I don't know, CMS and their innovation program to do this in a different way? So how are you trying to make sense of all this in your organizations? And let's do this one across all of the panelists. Maybe you could start, Will.
Want me to start?
Mm-hmm.
So where we've put our efforts at TriHealth is really the foundation of this is in patient-centered medical home. And we've been fortunate. We've got a grant from our parent organization, Bethesda, Inc., to help accelerate that. And we've established the patient-centered medical home model as our model of care within our primary care physician network. Now, not every practice is up on it, but by the end of the year, we'll have about 2/3 of our practices using the patient-centered medical home model. We think it has great promise for accomplishing those triple aim goals of lower cost and better quality and better patient experience. We think that it does hold promise for actually improving health and not just treating illness, and for engaging patients more in their care. So we think there's terrific potential. It's up to us to actually achieve that potential through the development of the model. And ultimately, it will be not in whether or not you have a NCQA recognized patient-centered medical home. That's not really the end goal here. The end goal is to move the numbers. And so the model is a means to the end, and we see that. But if you don't build the model first, you never get to see whether or not it actually can change the outcomes. And so that's our strategy. We're very much in the construction phase this year, and by next year we'll be much more focused. The balance will swing much more towards the output and the performance phase, and we'll see if we can move the bar on those metrics.
With regard to what we can do now with all this uncertainty, I think what we are picking to do is to do something. Like our speaker said at lunchtime, to pick something and to act is at least a place to start. We are doing that through a number of different initiatives, looking at specific quality initiatives, looking at some of the data, and making a plan for how we can look at some best practices and address practice guidelines on the outpatient setting, which we previously had not done before, even though there's a multitude of practice guidelines and best practices well established in the inpatient setting, to add that to the outpatient setting. We are also looking at patient-centered medical home as an option, not as our main option, but we do have a number of practices in a pilot right now to see what kind of benefits and outcomes we'll get from that, but looking at transforming all our practices in some way. So I think that those are the ideas that we'd like to focus on, best practices, connecting the inpatient and the outpatient. The system is also working on coordination teams, looking at what happens, the steps in the process from someone from the time they're admitted, their ER, their hospital, their discharge, their handoff, both to an ECF or to home, and then what kind of how we improve the follow-up into the outpatient setting.
Okay, from the employer's perspective, the way we think about payment, again, we like to use the word payment innovations. It's not as toxic as reform. So we look at it two ways. We have two financial partners. We have our employees and members. So that's plan design. You guys are all work, and what do your benefit designs look like? Because employees have to have, I don't necessarily like the term skin in the game, but we have to have financial incentives that are aligned with what the provider's being incented to do. So that's part of it. So employers have the obligation to put in the right plan designs. If it's high employee contributions, but all the touch points are free, low copays for drug, free ED visits, I mean, that's just irresponsible on our end. It contradicts what we're doing, what we're trying to incent through the provider compensation, which is the other leg of our compensation strategy or payment reform or innovations, where we think about it. So we look at that and how do we reward value, how do we reward quality, and we have to align the measures. So one of the things that we've been doing from GE is looking at our plan design and then looking at our compensation strategies with the health systems, but we've really tried to facilitate community dialogue. We don't think the employers can just come in and say this is how it will be done. As Will stated earlier, you can't just come in and say this is how we'll pay, so now just start changing your behaviors. That's short-lived, if effective at all. So we have to be deliberate and be thoughtful in how we put together a regional compensation strategy so we can start rewarding value. So we've, I think, been, I hope, viewed as helpful in having the systems discuss what would work from their side, from the supply side, if you will. But soon, hopefully, we can engage in multi-stakeholder discussions. So this is what the systems need, this is what the employers need and the health plans need, because they have the fully insured book, but ultimately they're paying claims on smaller employers. So it's really what the employer community would like to see. So there's got to be some common ground found. And then at the end of the day, we have to be able to have something that's attractive to CMS. And so, you know, depending on your provider, your patient panel, up to 50% or more of your patients are on Medicare. So at the end of the day, if we're not aligned with Medicare, then you got two sets of running rules. So we have to align with the national strategy, be cognizant of what CMS is trying to do and reward, and try to structure our programs around it. And where there's opportunity, help CMS think about this a little differently. And they're open to that. So that's how we're thinking about it. And Medicaid, I don't want to be absent of mentioning Medicaid as well. And they're willing to be at the table as well. So that's how we think about it.
I'm the only one, for some reason, that has to turn the microphone down. I don't know. There's problems. Okay. At Cincinnati Children's, Jim Anderson, our former CEO, used to have a line that said, "Start before you're ready." As an academic institution, I think maybe we tend to attract culturally people who we can plan forever and tighten up the design and go back and do it again and write a paper about it. But at the end of the day, we have to begin and execute the work. And so it's in that light that we recognize we don't have the answer up front about what it takes to design and execute to achieve accountable care, regional improvement, population improvement. So we're spinning multiple pilots so that we can, as quickly as we can, learn from multiple initiatives in aggregate what it's going to take. So I'll give you examples of pilots that we're spinning to understand what it takes to move population dials on quality and cost metrics. First, we put together a population health section of our Anderson Center for Health Systems Excellence. We have an asthma initiative, obesity, infant mortality reduction, unintentional injury. All disparate initiatives, all different denominators, but we're trying to understand what QI, IT, measurement infrastructure it takes to be successful in moving the outcome measures for those populations and create a cross-learning between those teams so that we can rapidly or more rapidly transfer those learnings so one initiative can benefit from the other within the time course that they're up and running. The other thing we're doing is a bit of a different denominator. We have some primary care sites in the community, one of which is predominantly Medicaid up in the Fairfield area. And that's a defined population linked to a primary care site, and we're going to try to figure out what is the model to move that population in the right direction. The organization that I'm most closest to within Children's, the Physician Hospital Organization, we have 200,000 of the 500,000 kids in the region within our organized system. And we're trying to figure out what does it look and feel like to move that population in the right direction. And all of this, we try to create an overlying learning structure around it within our system so that as one initiative is experiencing successes, challenges, the leaders of the different initiatives come together on a regular basis so that we do have cross-learning, so we're not all reinventing the wheel. And if I were to apply that model to the work that's going across the adult and the pediatric sides of the fence within this community, I think there's an enormous opportunity to strengthen our learning system between Mercy, TriHealth, UC, and Children's so that the cross-learning is actually even broader than it is today. The other thing I just wanted to say is this all starts with what we as an organization are committing to from an quality improvement standpoint, and that's what's driving the spinning of these pilots and the investment. And we're leading with that quality improvement work. And what we as an institution hope to do is let the payment reform model that makes the most sense for us evolve naturally rather than front-loading our focus on a payment reform model. It's consistent with what I tried to emphasize earlier, but now I'm trying to put the Cincinnati Children's overlay to that. So that's my comments on that, what we're doing in that sphere.
Okay, let me throw out a general question here that I'm really springboarding off of some of your comments, Craig. You mentioned the concept of a regional transformation and multi-stakeholder functions. I would observe that with I don't know, 30-day readmissions is a good example. If TriHealth discharges somebody and they're readmitted within 30 days somewhere else, that's a financial problem now for TriHealth, even though the individual was outside of the TriHealth organization. So a lot more dependence on people outside of the organization. So how are you thinking about that? I mean, how can organizations here in the tri-state begin to work together to really function more as a system and address these interdependencies focused around the patient rather than an organization? Well, whoever.
I would just cement that to say, again, being a payer, our folks live all over. I got a plant out in Adams County. I got a plant in Vandalia. I got folks on the tarmac at CVG. Of course, the big plant in Evendale, all over. So when you talk about readmission rates at pick it, doesn't matter, any of the facilities, same facility readmission rates will be high single digits or whatever it is. I don't know what it is. But as a payer, I don't care where they're readmitted. I mean, it's another bill I get, and I have kids that go to pediatricians at Group Health Associates, but then they see a specialist at Children's. And I mean, there is no one, we're not one Kaiser, we're not one Geisinger, and I'm happy for that. But our population, this region of 2.2 million folks, live across the system. So, there's going to be a challenge of patient attribution and who you're accountable for. But care is still, I think, going to be delivered across different entities, and we have to be able to, but there's still going to be somebody accountable for that. So people are going to be very interested in where did you go for that back surgery, or where did you go for that particular procedure, and what could we have done perhaps to manage that, especially if it was inappropriate. So it's just the realization that folks go across the river. Sometimes you get in discussions and the river's getting wider and deeper. But there's still a bridge, and they're going to build a new one. So, I mean, our folks will be going back and forth. It's one region. So.
I think as we start to look at the community responses to this, I think it's a challenge that we have in this city and cities across the country, where while we are very collaborative across our different systems, we still compete with each other. And so you have to, there's a good and bad to both sides of that, and you have to recognize that. And my sense is that the collaboration around clinical improvement and sharing of data across systems is probably going to start around specific initiatives. And the readmission is a good one, Bob, because we're all vested in improving in that. We all have something at stake. There's already a group that's working through the Health Council and OHA on improving reducing the number of readmissions in Cincinnati. We know we will all do a better job if we can figure out how to share that information across systems, so we can see the benefit right away. I think as you start to sort of broaden, gee, we should be sharing this and sharing that, what happens is the people who are actually down in the trenches, they get confused. They say, am I supposed to be collaborating this week, or am I competing with these guys this week? Am I trying to pick up market share? Am I trying to share my data, et cetera? And I think that's natural. I mean, I don't think that's a bad thing. I think that the competitive part of this makes all of us better providers, quite frankly. So I'm a supporter of that. But I do think we are capable in Cincinnati of good collaboration, and I think how it's going to progress is sort of project by project, and then potentially at some point in the future you get to critical mass and you say, gee, we got so many projects, there's not much gap in between the projects, et cetera. But I think that's where we are right now.
I think another benefit for us in the tri-state with patients accessing care so many places is to emphasize patients having a medical home. If it's an official patient-centered medical home, or it's the site where they feel most comfortable, or the provider where they have the best communication, that's something that can help for the region, so that when patients access care at different places, they know, and all these other sites of access know, that it's important to get information back to the patient's home. The reason for that, when Mr. Moody was speaking this morning, he talked about that Ohio is only 44th in outcomes for such an educated state, which has so many industries, 44th in outcomes, yet we were 14th in access. So we've got patients accessing their primary care, their orthopedist, their cardiologist, the endocrinologist, the dermatologist, the ER at St. E's, and the ER at B North, and they're accessing, and we wonder why we have so much cost, because they don't know where to centralize their care. And we can use some resources such as HealthBridge and such as so many offices getting onto EMR to get that information into one place, so that if an individual has gone to many institutions and that information comes back, then we can address that with them and with the other providers. How can we streamline your care? How can we give you better access at one place so you don't feel you need to access so many other places? So something like HealthBridge, or if there's any other citywide link between the EMRs, that would give hospitalists, ER doctors, subspecialists, and primary care doctors a way to communicate on the patient.
Just one more comment on the. Is this on? Yeah, just one more comment on the around regional transformation. And Will brought up competition. I think that's very important, that it keeps us sharp, and it will force that continual improvement that we have, as long as we have the information to improve. But from an employer's perspective, it really is about economic viability. It's about the economic viability of this region, and that's how we look at it. So we can't just transform TriHealth, or just can't transform St. Elizabeth's, or just Children's. We have to transform the region where health and healthcare can become a competitive advantage to this region, so employers want to come here, locate here, because it's an efficient place and it's an attractive job market. It's where providers want to practice, because the compensation rewards value and they actually can practice medicine. And it's a place where families want to locate. So that's really, at the end of the day, what an employer would like to see. And healthcare can either be a drag on a community, as a lot of communities are struggling with it, or it can be an advantage. And we're hoping we can transform this region so it becomes an advantage.
Okay, let me throw out a bonus question here, meaning one that you might not have seen before, and I'll invite anybody that would like to jump in and talk about it. We started out talking about payment reform and ACOs. We sort of evolved from, gosh, we really have to think about transformation. We talked about your interdependence with other providers. On the stage here, we've got 3 hospitals and an employer represented. My question to you is this: what should the role of payers, Medicaid, CMS, commercial payers, what should their role be with you in healthcare transformation? That if you could wave a wand and make it work, what would it look like?
I'll hit the buzzer. Here we go. Bonus round. I think that it's what I alluded to before. We are trying hard to advance the triple aim, to improve quality, to improve patient satisfaction. But none of that makes any sense unless you can also reduce costs. We understand that. You can't improve access and have more people insured and not have lower costs. I mean, somewhere along the way you've got to make all the ends meet, and I think the providers understand that. I think there's two critical things that we see is lacking, and one is a long-term commitment to paying for and rewarding those organizations that actually reduce costs and improve quality and improve patient experience. And the second is getting the data that we need to be able to measure that. So, some of it is controlled inside the system, but a big piece, if we want to reduce costs, we've got to get the cost data that we're accountable for available to us in a timely manner so that we know if we're succeeding or not, and where we're not succeeding, where we can put in interventions to do that. So if I could wave the magic wand, and I understand, and I'm not here to bash any of the payers in the room if there are payers, I understand that that there are barriers to that. There are legitimate barriers at all levels, but to have a predictable and sustainable payment system and to be able to have the cost data needed to measure our performance, those would be the two things I'd look for.
Hey, let me give this one a shot. I deal in the payer world a lot in the context of my job, and I would say if I could wave a magic wand, it would be that the design of the programs that the payers introduce into the market were, part of me wants to say totally driven by the provider side, but I know that's not realistic. But there's really a true partnership in how those programs are designed so that they're getting closer to what I said earlier of being viewed as accelerating, truly accelerating improvement, rather than having the unintended effect of distracting the conversation. Because, in the history of payer-driven reward models, oftentimes there's huge arguments over the quality of the data, the numerator, the denominator, the attribution issue, that people get so caught up in problems with the design characteristics that we've lost sight of the bigger picture. And people ultimately don't feel as if their performance on quality is accurately being assessed. So I'll give on the provider-driven design models, although we did pilot that with Anthem a couple of years ago, and it was very, very successful. But maybe a hybrid model is, at least can we agree to use the best available data to populate the numerator and denominator, even if it's not solely driven by the payer claim system. So if providers have the wherewithal to have the cleanest numerator and denominator and can show that they have reliable, valid data, why couldn't that be widespreadly trusted and used as the best source of assessing and rewarding quality, and also the same data that the public would see, and the same data that the providers are actually using to improve care? Wouldn't that be a wonderful world where the data that we're all using for our improvement projects is actually the same data that we're using to reward quality in the marketplace? There's direct alignment, and I think that takes a lot of the noise out of the system. And actually, I think the dollars that payers, both government and commercial, are investing in these reward programs would actually go a lot longer, a lot further in terms of delivering a return on investment. And I think it would be viewed a lot more positively, in the market. So I think those are some opportunities, I think, to work in tandem at a fundamentally different level than perhaps we are today.
Okay. Greater Cincinnati's been a leader in the use of health information technology and information exchange. Are there specific concerns or opportunities that our community should know about when thinking about transforming care and moving to the next level, and in terms of the health IT and the exchange of data? Problems, concerns, opportunities, because we've got this this enhanced infrastructure.
I'll try and let you guys go. The way I look at our infrastructure right now is we have a one-lane road. It's maybe even paved. Most communities don't have a road. They don't even have a map. So that's a problem, right? Because people are getting around trying to figure out where the road should go. So they're kind of stuck. We have a road. So the opportunity, though, is we need a 6-lane highway, and we need to blow it out. And what I find, and I'm privileged enough to work with really smart people and folks that are willing to share their knowledge, and I learn from them every day. But I find that we're building out this infrastructure, we're building out this road, if you stay with that analogy, and we kind of know where we need to go. We got the one lane, why would we deviate from that? And we're kind of arguing over gravel and rebar, you know? And just fighting over the raw materials, fighting over the data. And the data should be informing where we should put up the next Rookwood Commons, because that's really what you build the infrastructure for, is for commerce and to engage folks and to create opportunities for a community. And we're still arguing over where the dump trucks go and all that. I don't think we should be competing necessarily for the data. And so we're not there yet. So actually I should have, you know, if I'm waving that wand for all of us as payers and suppliers and systems, we'd have trust. And we can put the data in and look at it objectively and say where are opportunities, and then compete on the data. And I think people will win on execution, not on the data and who has more information. And you know, if we can do that, I think I could line up a bunch of payers that would sign like I'm 45. I would love to sign a 15-year deal. You know, a long-term financial commitment, and say, here's what we'll do. We'll do it right here on this table, and turn the market. So that's where I think our opportunity is, but there's a lot of pitfalls in that.
You know, I think that there's well, two of the big barriers on sharing data across systems and such. And Dr. Masashari, he referred to one at lunch, which is security issues. So to the extent that we have security issues across our country at the hospital level, and I don't know what the state of security is among all of our providers here in Cincinnati, but we're all worried about it. And so you think about that, about being nervous about protecting the data inside your institution, and now you want to share it with 6 other people, and you know, that just, you know, gets us all jumpy, I think. And I think the other piece of that is, you know, the HIPAA regs. The federal government's done a good job of raising awareness about privacy issues to the point where they've scared us to death. And so, you know, the regs aren't clear. How they get enforced aren't clear. So people become very, very conservative in dealing with making decisions about what you can and can't share, and how many consent forms do you have to have signed off, and how many, you know, how long do they have to be, and how much of it has to be in big bold letters with caps, you know, so that you've fully informed people that you're going to use their data. And that gets in the way. It's a very practical concern, because the last thing any one of our organizations wants is to be on the front page of the paper saying, gee, we had a HIPAA violation. Why don't you come to our hospital next week? I mean, you know, so I think those are sort of there's a lot of other practical concerns, but those are really big barriers that are emotional, and I don't think that they're just emotional. I think that there's real reasons to be concerned, but people get all wound up in that, and it's a barrier that we're seeing in Cincinnati, I think, right now.
You okay if I come?
Sure.
Okay. I think there's huge.
Give us the right answer here.
No. The guy at the end of the table usually doesn't have it right now. But I think there's huge value to places like HealthBridge and the Health Information Exchange and the central data that they'll be collecting that all organizations could benefit from and pull down to support their improvement efforts. But it's this striking the right balance between the centralized infrastructures and the distributed infrastructure. So all of us, all our organizations, and even if you're a primary care practice, we're all on our own journey around quality improvement and information technology. And it's finding that sweet spot where we can continue to execute our journey and benefit from, in perhaps different ways, from the centralized infrastructures across the community, like HealthBridge, like the Health Improvement Collaborative, and the Greater Cincinnati Health Council. But the look and feel of those partnerships are different. So how does an entity like HealthBridge strike that right balance so that they are providing maximal benefit to each partner, but in ways that are meaningful to that partner and the populations they serve? And those models look different, and I think sooner than later we have to find our way to what that looks and feels like across this community, because perhaps it looks different for Mercy than for TriHealth for understandable reasons. But the win-win is still there.